Second, sir. Good morning.
గణపతి గుడ్ మార్నింగ్. రీసౌండ్ వస్తుంది చూసుకో ఒకసారి.
సార్ ఇప్పుడు ఎలా ఉంది? హలో.
ఇప్పుడు బాగానే ఉంది గణపతి.
సార్.
ఏంటి జయరామ్ వేడి?
అదే సార్ మెసేజ్ పెట్టాను, ఇప్పుడే వస్తా అన్నారు సార్.
ఓకే, ఒక 10 minutes ఆగి 8:10 స్టార్ట్ చేసేద్దాం. ఎంతమంది ఉంటే అంతమంది.
సరే.
వేరే రోజు కదా, కొంచెం అటెండెన్స్ తక్కువ.
అవునవును. గుడ్ మార్నింగ్ సార్.
గుడ్ మార్నింగ్.
గుడ్ మార్నింగ్ సార్.
గుడ్ మార్నింగ్. ఎవరు ఇష్టం?
ఫైన్ సార్.
మాకు ఓంకార్ కనపడ్డాడు.
ఎక్కడ సార్? విజయవాడ ఎక్కడికి వెళ్ళాడు మనోడు?
కాదు, హైదరాబాద్ లో ఎక్కడో ఎవరు లేరు కదా, ఎక్కువ మంది ఉన్నారా?
లేదు సార్.
లేదు సార్, గణపతి మీరు అంతే.
ఓకే ఓకే. ఎక్కడో అక్కడ ఊరి చివర శంషాబాద్ తర్వాత నార్కోడు హయత్ నగర్ ఎక్కడో ఉంది. అక్కడ నేను రేపు పొద్దున నిన్న పొద్దున అక్కడ కాన్ఫరెన్స్ అయిన తర్వాత ఎవరినో కలుద్దాం నేను వెళ్ళి బండి మీద, నేను ఇంకొకటి బండి మీద అలా వస్తూ సుధీర్ అనేవాడు అసలు దొరకట్లేదు కాఫీ ఎక్కడ ఉందాం అని చెప్పేసి ఏదో సిప్ కాఫీ ఉందని ఆగాం. అయితే అక్కడ మాల వేసుకుని నించో ఉన్నాడు. ఇక్కడ అసలు కొంచెం షాక్ తిన్నాను కొద్దిసేపు. ఏంటి ఇక్కడేంటి నేనేంటి అసలు ఏం జరుగుతుంది ఇక్కడ చూసారా, అలా అయిపోయింది.
ల్యాండ్స్ అని కొనేస్తున్నాడేమో సార్ అక్కడ.
ఏం చేస్తున్నాడు ల్యాండ్
అన్నాడు సార్. మరి 2 days విజయవాడ వెళ్తున్నాను సార్ అన్నాడు.
అదే నేనేది ల్యాండ్ కొంటున్నాడో ల్యాండ్ గ్రాబింగ్ చేస్తున్నాడో తెలియదు మరి. ఇక్కడ అలవాటు పడ్డాడు ల్యాండ్ గ్రాబింగ్ చేయడం. ఇంకా ఎవరు జాయిన్ అవ్వలేదేంటి?
అదే మెసేజ్ పెడతాను.
ఇదేమన్నా మంచి కార్తీక సోమవారం ఏమన్నా పూజలో ఉన్నారా ఏంటి జనాలు?
ఏమో సార్ అయ్యి ఉండొచ్చు. 8 మెంబర్స్ జాయిన్ అయ్యారు. ఒక 2-3 మినిట్స్ ఆగి స్టార్ట్ చేసేద్దాం సార్, మెల్లిగా జాయిన్ అవుతాం.
అలాగే 8, 6, 7 స్టార్ట్. స్టార్ట్ చేసేయండి.
గణపతి స్టార్ట్ చేసి.
అవును సార్. Good morning all. Today my topic is anesthesia implications of diabetes mellitus. Diabetes mellitus, it results from an inadequate supply of insulin and or inadequate tissue response to insulin, producing hyperglycemia with eventual microvascular and macrovascular complications. The diagnosis of diabetes mellitus as per ADA American Diabetes Association is a randomized plasma glucose concentration of 200 mg per deciliter high with classical signs and symptoms like polyuria, polydipsia, unexplained weight loss, or fasting plasma concentration of more than or equal to 126 mg per deciliter after no calorie intake for 8 hours. Or an abnormal oral glucose tolerance test in which the glucose concentration is 200 mg per deciliter or higher 2 hours after a standard carbohydrate load, or HbA1c is more or equal to 6.5. HbA1c is a stable glycosylated hemoglobin. It indicates average plasma glucose concentration during the preceding 60 to 90 days. It performed 2 times a year. The normal range of HbA1c is 4 to 6%. If it is increased, there may be a chance of microvascular and macrovascular disease if more than 6.5. Classification of diabetes: type 1, type 2, gestational and other. Type 1 diabetes, it constitutes 5 to 10% of diabetes mellitus diagnosed, mostly appears in children and young adults. It is caused by a T-cell mediated autoimmune destruction of beta cells of pancreas. At least 80 to 90% of beta cells function must be lost before hyperglycemia occurs. Ketoacidosis indicates the severe insulin deficiency. Type 1 treatment mainly by insulin. Type 2 diabetes, it involves 90 to 95% of people with diabetes. It is associated with older age, obesity, family history of diabetes mellitus, prior history of gestational diabetes, and physical inactivity. It is caused by insulin resistance and gradual decreased production of insulin over the following years. Treatment mainly diet control, exercise, and medications like insulin, oral hypoglycemic drugs. Gestational diabetes, if hyperglycemia is diagnosed during pregnancy, it's called gestational diabetes. Occurs in 2 to 5% of pregnancies. It is caused by placental hormone changes that affect insulin function, mainly on resistance. Screening usually occurs during 24 to 28 weeks in high-risk patients. Women with history of gestational diabetes have a 20 to 50% chance of getting type 2 diabetes within 5 to 10 years. Other specific type of diabetes mellitus are genetic disease of the exocrine pancreas, drug-induced infections, endocrine disorders. Treatment of the primary cause may resolve the diabetes, but lifestyle modification and medication may be needed as well. Drug therapy in diabetes mellitus, mainly by oral anti-diabetic drugs or insulin injections. Oral anti-diabetic drugs classified according to mechanism action into 3 categories. One, enhance insulin secretions. Second one is overcome insulin resistance, and other. To enhance insulin secretion, there are 2 types of drugs are there. One is ATP-dependent potassium channel blockers, and second one is DPP4 inhibitors, dipeptidyl peptidase 4 inhibitors. Potassium channel blockers mainly divided into 2, sulfonylurea, these tolbutamide, glibenclamide, glipizide, gliclazide, these are sulfonylureas, and non-sulfonylureas are meglitinids or rapaglinide, netiglinide. Second, to overcome insulin resistance, there are 2 types of drugs. Biguanides, example metformin, thiacholidodians, example pioglitazones. Other drugs are alpha glucosidase inhibitors, acarbose, amylin analogs, D2 antagonists, and sodium glucose co-transport inhibitors. Coming to IV insulins, there are 5 types of IV insulins are there. Ultra rapid acting, example aspart, onset of action is 10 to 20 minutes, peak of action 1 to 3 hours, and duration of action 3 to 5 hours. Second, rapid acting, example aspart, glulicin, lispro, onset of action in 15 to 35 minutes, peak of action 1 to 3 hours, and duration of action 3 to 5 hours. And regular or soluble insulins, onset of action half an hour to 1 hour, peak of action 2 to 4 hours, and duration of action 5 to 8 hours. NPH, neutral protamine insulin, it is intermediate acting, onset of action in 2 to 4 hours, peak of action 4 to 12 hours, and duration of action 12 to 24 hours. Basal or long acting analogs are glargine, ditamir, onset of action 2 to 4 hours, peak of action 8 to 12 hours, and duration of action 20 to 24 hours. Coming to complications of diabetes, divided into mainly by 2, acute and chronic. Acute complications are diabetic ketoacidosis, hyperosmolaremic non-ketotic syndrome, hypoglycemia, and infection. Chronic complications of diabetes are macrovascular diseases, neuropathies, and diabetic foot disorders. Coming to diabetic ketoacidosis. Diabetic ketoacidosis is a complex metabolic state of hyperglycemia and hyperglycemia acidosis. Causes are mainly infection, missed insulin doses, other physiological stress like MI, severe trauma, pancreatitis, and pregnancy. Pathophysiology. In diabetic ketoacidosis mainly to occur 1, hyperglycemia, 2, lack of insulin. Because of hyperglycemia, there will be osmotic diuresis, loss of free water and electrolyte. It can lead to hypovolemia issue, hypoperfusion, lactic acidosis, and electrolyte imbalance. Due to lack of insulin, there is a ketoacidosis because of the production of the estoestrone, beta hydroxybutyrate. These are produced by proteolysis and lipolysis. Signs and symptoms of diabetic ketoacidosis are hyperglycemia, elevated serum ketone, acidosis as evidence of by pH 6.8 to 7.3, and low bicarb levels, low osmolarity, dehydration, electrolyte depletion, GI distress, respiratory distress. Treatment of diabetic ketoacidosis. Managing diabetic ketosis is an intensive care unit during the first 24 to 48 hours is always advisable. Correction of fluid loss with IV fluids. Initially, first hour bolus with 1 liter, first hour 1 liter, after 2 hours for 6 hours 1 liter, followed by 250 to 500 ml per hour, according to intravascular fluid assessment, and correction of hyperglycemia with insulin 0.1 unit per kg bolus and followed by 0.1 mg per kg per hour infusion. Correction of electrolyte disturbances, particularly potassium loss, and correction of acid-base balance and treatment of concurrent infection if present. Second one, hyperosmolar hyperglycemic non-ketotic syndrome. There are 4 clinical features present in HHNS syndrome. One is hyperglycemia, more than 600 to 2000 milligram per deciliter, mild or no ketosis. Third, hyperosmolality of plasma or serum, more than 350 milliosmoles, and profound dehydration. 10 to 20% of mortality rate with HHNS, and risk factors include elderly with type 2, undiagnosed diabetes mellitus, prolonged hyperglycemia. Signs and symptoms are hypotension, dehydration, tachycardia, decreased mentation, and neurological abnormalities, mainly focal. Treatment: if plasma osmolarity more than 320 milliosmol per liter, large volume IV fluids, 0.5% normal saline should be administered until osmolarity is less than 320 milliosmol, followed by 0.9% normal saline. Insulin infusion at the rate of 0.1 unit per kg per hour if electrolyte imbalance are less severe compared to diabetic ketoacidosis. Hypoglycemia. If plasma glucose less than 50 milligram per deciliter, it may occur in all type of diabetes mellitus and is usually related to illness. Common causes of hyperglycemia is exogenous insulin or oral diabetic medication that increase insulin production. Exo-alcohol consumption, especially without adequate food intake. Impaired or renal function, exo-exercise. Signs and symptoms: by adrenergic activation, sweating, tachycardia, palpitation, restless, and pallor. Neuroglycopenic symptoms are fatigue, confusion, headache, somnolence, convulsions, and coma. Treatment: if mild, 60 to 40 milligram per deciliter, ingestion of 15 grams of carbohydrate, and monitor blood sugar levels and treat until euglycemia. If moderate to severe, if is less than 20 milligram per deciliter, IV glucose 0.5 gram per kg IV and IM glucagon 0.5 to 1 mg preferably. Monitor blood glucose levels and treat until euglycemia. Wound healing and infection. Infections are the common cause of diabetic complications. Wound healing is impaired in diabetic patient due to alteration in leukocyte function, decreased chemostasis, impaired phagocytic activity, reduced intracellular killing. Commonly seen infections are cutaneous, furuncles, carbuncles, cellulitis, upper respiratory tract infections, UTI infections, ear infection. These must be treated aggressively. And the microvascular complication. Microangiopathies affecting the capillaries and arterioles of the tissue, mainly retina. It causes retinopathy and renal glomeruli. It leads to nephropathy. Retinopathy development progressive, largely depend on the duration and severity of the hyperglycemia. Early detection and treatment can be beneficial in visual restoration. And uncontrolled hypertension is an aggravating factor to diabetes. Nephropathy. 20 to 40% of chances developing with a diagnosis of diabetes mellitus. Earlier occurrence in type 2 than type 1 diabetes. Pathophysiology mainly by glomerulosclerosis with glomerular basement membrane thickening. Signs and symptoms are microalbuminuria, proteinuria, decreased creatinine clearance. Aggravating conditions are hypertension, neurogenic bladder, UTI, nephrotoxic drugs. Treatment includes improved blood sugar control, hypertension management, protein restriction, if required, dialysis and kidney transplant. Macrovascular complications responsible for 80% death in people with diabetes mellitus. Major vessels affected are coronary arteries. It can lead to MI. Cerebrovascular affected, it can lead to CVS, and peripheral arteries. It can lead to peripheral neuropathies. Peripheral neuropathy. 50% of diabetic patients develop peripheral neuropathy after 25 years. Distal symmetrical diffuse sensoromotor polyneuropathy is most common. It also called stocking glove neuropathy. Foot ulcers develop due to loss of cutaneous sensitivity to pain, temperature, and improved perfusion. Treatment include optimal glucose control, NSAID, antidepressant, anticonvulsant for pain relief. Diabetic autonomic neuropathy. Autonomic disturbances can be subclinical or clinical. Cardiovascular autonomic neuropathy is a common type of diabetic autonomic neuropathy. Resting tachycardia and loss of heart rate variability during deep breath are early sign. In advanced stages, severe orthostatic hypotension is present. Impaired respiratory reflexes and impaired ventilator response to hypoxia and hypercapnia also present. Gastrointestinal diabetic autonomic neuropathy, it can lead to impaired gastric secretion, gastric motility, causing gastroparesis, nausea, vomiting, early satiety, bloating, and gastric pain. Preoperative assessment and management goals for the diabetes mellitus. Avoidance of the hyperglycemia, hypoglycemia, maintenance of physiological electrolyte and fluid balance, prevention of ketoacidosis, reduction of overall patient morbidity and mortality, establishment of certain glycemic target levels. Preoperative evaluation. By taking history, type of disease and duration of the disease, patient and medication, we have to look for anti-diabetic, insulin, other drug therapy, dosing, and time of interval. And we have to ask for the risk factors like smoking, alcohol, sedentary lifestyle. And we should ask for the recent infections. And physical examination, we should look for the orthostatic hypotension, and we should examine the fundus to rule out diabetic retinopathy, and we look for stiff joint syndrome and Preyer's sign. Specific assessment and management, evaluation of glycemic control, cardiovascular complications, diabetic nephropathy, gastroparesis, autonomic neuropathy, and musculoskeletal airway. Glycemic control evaluation. It can be done by following 4. HbA1c, recent blood and capillary glycemic values, episodes of hypoglycemia, episodes of hyperglycemia, and acidosis. H1A1c, mean control or previous 3 months, and if increase in 1% of HbA1c can lead to 40% increase in cardiac risk. If HbA1c is more than 7.5, there will be increased risk of postoperative complications. Recent blood and capillary glycemic value, if it is more than 200 milligram per deciliter, will increase the post-op mortality and mortality. If it is less than 180 milligram per deciliter, decrease the infection, duration of hospital stay, and mortality. Target for perioperative glycemic is 80 to 180 milligram per deciliter according to ADA. Evaluation of cardiovascular complication. Diabetes are more prone to ischemic heart disease, hypertension, peripheral vascular diseases, cardiomyopathy, perioperative myocardial infarction. Ischemia may be silent as a result of neuropathy. Routine ECG should be performed on appropriate stress testing like provocation test, stress echo, stress MRI if in doubt. Pre-clinical stage of congestive heart failure, if required, you have to look for ECG, LVH, 2D echo, proBNP, and BNP. Cardiologist referral should be given for specific management. Evaluation of diabetic nephropathy, most frequent neurovascular complication. It affects 30% in type 1 diabetes mellitus and 20% in type 2 diabetes mellitus. Impact of the diabetic neuropathy. Diabetic neuropathy, it is an independent risk factor for developing acute renal failure. We should avoid nephrotoxic drugs in this patient, and we should maintain minimum MAP is more than 60 to 70 ml of HCl to maintain adequate renal perfusion. Evaluation of gastroparesis. Gastroparesis is caused by a delay in gastric emptying without any gastric outlet obstruction. Increased gastric content increase the risk of aspiration. Always ask about symptoms of reflux and consider a rapid sequence induction with required pressure even in elective procedures. Prescribe an H2 antagonist such as ranitidine 150 mg and metoclopramide 10 mg at least 2 hours preoperatively in gastroparesis patients. Evaluation of neuropathy by these following tests: beat to beat heart rate variation, heart rate response to standing, heart rate response to Valsalva maneuver, orthostatic hypotension, blood pressure response to sustained hand grip. Beat to beat heart rate variation. Patient at rest and supine heart rate monitoring ECG while the patient breathes in and out at 6 breaths per minute. The difference is more than 15 beats per minute is normal. If it is less than 10 beats per minute, it is abnormal. Heart rate response to standing. Heart rate increase on standing during continuous ECG monitoring. The RR interval is measured at beats 15 and 30 after standing. Tachycardia is followed by reflex bradycardia. The 30:15 ratio should be more than 1.03. If it is less than 1, the patient is having cardiac autonomic neuropathy. Heart rate response to Valsalva maneuver. The subject forcefully exhale into the mouthpiece of a manometer to 40 mm of HC for 15 seconds during ECG monitoring. Healthy subject develop tachycardia, peripheral vasoconstriction during strain and overshoot of bradycardia and rise in BP with release. The normal ratio of longest RR to shortest RR should be more than 1.2. If it is less than 1.10, then patient is having autonomic neuropathy. Orthostatic hypertension. BP is measured in supine subject. The patient stand and systolic pressure is measured after 2 minutes. The normal response fall of systolic blood pressure is less than 10 mm of Hg. If it is more than 30 mm of systolic blood pressure or more than 10 mm of diastolic blood pressure indicates autonomic neuropathy. And sustained hand grip. If patient is sustained hand grip for more than 5 minutes, if diastolic blood pressure increase more than 16% is normal. If it is less than 10%, patient is an autonomic neuropathy. Evaluation of musculoskeletal and airway. Stiff joint syndrome, glycosylation of collagen in the cervical and temporomandibular joint. It can lead to difficulty in, it is a sign for difficulty in orotracheal integration. It can be tested by prayer sign. Positive if the patient asked to bring both the palms together, unable to approximate the palmar surface of the phalanges joints despite of maximal effort. It is positive sign. Anesthetic management. Diabetic patient should be placed first on the operating list to shorten the pre-operative fasting and potentially allow normal oral intake later that day, same day. Avoid hypoglycemia as this can cause irreversible cerebral damage, and avoid severe hyperglycemia to minimize dehydration, metabolic upset. Type 1 diabetics need insulin to prevent ketogenesis. Gastroprokinetic drugs or H2 blockers should be prescribed. Start GA drip on the day of surgery. Check blood sugar every 1 to 2 hourly and serum electrolyte on the day of surgery. Continue all diabetic medication until the day of surgery, except chlorpromide. Stop 3 days prior as long-acting. Substitute with short-acting sulfonylurea. Metformin, if major surgery because as a risk of lactic esterosis. Glitazones, long-acting insulin. Long-acting insulin should be substituted with the short or intermediate-acting insulins. Anesthetic drugs in diabetes mellitus. Benzodiazepines. Effect is minimal in usual doses, but paradoxical stimulation of growth hormone and decreased glycemic response to surgery. Opioids, these are hemodynamically, hormonal, and metabolically stable, so better control in patient with autonomic neuropathy. Ketamine has dual effect. In low doses, it causes hyperglycemia. In high doses, it causes hypoglycemia. Propofol, it causes profound hypotension, bradycardia in diabetic patient compared to normal patients. And etomidate, it causes less hypotension, but it suppresses the adrenocortical function and decreases the hyperglycemic response. Volatile anesthetic. Isoflurane inhibit insulin production, hyperglycemia occur, and it is dose-dependent manner. Sevoflurane has no effect on diabetes mellitus and glycemic control. Neuromuscular agents. No significant glycemic response. Avoid succinylcholine because of neuropathy and potassium hyperkalemia. Coming to intravenous fluids in intraoperative management. It should contain sufficient glucose to minimize catabolism and permit insulin infusion. It should contain potassium. It should be isotonic. Should not cause hyperchloremic estesis. So preferably 5% glucose with 0.45% normal saline and 20 millimole of KCl. Avoid ringer lactate. it causes neoglucogenesis in liver. If large volume, it may complicate blood sugar level. Normal saline, in large volume, it causes hyperchloremic metabolic acidosis. Intraoperative glycemic control. Target is 150 to 200 milligram per deciliter. Relative hyperglycemia, it causes significant morbidity and mortality. If blood sugar we maintain between 140 to 170, that can lead to low risk of adverse outcome. And it also depends upon the length of operative procedure. Short or minor procedure, pre-glucose maintenance protocol is sufficient. If it is major or complex surgery, variable rate of an IV infusion should be started, like Zik regimen, sliding scale regimen, tight control regimen, and Vello regimen. Zik regimen or Albert regimen. Blood sugar to be stabilized 2 days prior to surgery before starting Albert regimen. Start infusion at the rate of 100 ml per hour with 10% DNS, 10 millimoles of KCl, 10 units of insulin. Monitor blood sugars every 2 to 3 hours. If blood sugars are less than 90, decrease the insulin to 5 units. If it is 90 to 180, insulin should be 10 units. If it is 180 to 360, the insulin level should be 15. If it is more than 360, the insulin level should be 20. Second is sliding scale. Here, 50 units of soluble insulin dilated to 50 ml with normal saline and run at a rate according to patient blood sugar. If it is less than 120, stop. If 120 to 150.5, 150 to 182, according to, you have to titrate the dose and maintain euglycemia. Tight control regimen. Indications for tight control regimens are pregnancy, CPP, neurosurgery, patient requiring postoperative mechanical ventilation, ICU care. Advantages of tight control regimens are improved wound healing, lessen infection, and better neurological outcome. Disadvantages: more chance of hypoglycemia and require frequent monitoring. We should aim for blood glucose level between 79 to 120 milligram per deciliter. And we commonly use is 5% DNS at the rate of 50 ml per hour per kg. Pit back regular insulin at the rate of 150 or 100 if the steroid or severe sepsis. And regional anesthesia, epidural or spinal anesthesia. Normal effect on glucose metabolism and inhibits catecholamine release irrespective of spinal segment level. Hypoglycemia better appreciated, and it has less aspiration, postoperative nausea, vomiting, and thromboembolism chances. Early reception of oral intake, subcutaneous insulin, and oral hypoglycemic agents. Caution should be taken because autonomic neuropathy, it can lead to severe hypotension after giving epidural or spinal anesthesia. Sometimes epidural abscess may occur. This patient may have nerve injuries or existing motor and sensory neuropathy. So these should be documented. Thank you. Srikanth sir. Srikanth sir.
Hello, sir. Good morning, sir.
Chaitanya, good morning.
Sir, ringer lactate need not be avoided, kada?
అంటే లాస్ట్ డోసెస్ లో మనకి హెపాటిక్ మెటబాలిజం ఇది అవుతుంది కదా, లాక్టిక్ ఎసిడోసిస్ వచ్చే ఛాన్స్ ఉంటుంది, అందుకని అవాయిడ్ చేయమని.
అంటే అదే అంటే ఈ మధ్య ఈ డిస్కషన్ ఎప్పుడు వచ్చినప్పుడు there are articles which suggest that there is no difference in using NS or RL. Unless there is అంటే లాక్టేట్ బాగా ఎక్కువ ఉంది పేషెంట్ లో లేకపోతే there is no problem in using ringer lactate in diabetics అని చెప్పి.
ఓకే, థ్యాంక్ యూ
సార్. వెల్లూరు రెజిమ్ నేను చెప్పలేదు సార్.
వెల్లూరు రెజిమెన్ సార్ ఇది స్లైడింగ్ స్కేల్ లాగా ఉంటుంది సార్, వెల్లూరు రెజిమెన్ కూడా ఆల్మోస్ట్ అది మెన్షన్ చేసాం కానీ చెప్పలేదు సార్.
వాట్ ఈస్ ఇన్సులిన్ రెసిస్టెన్స్?
Because of adipose tissue, sir, some glycoproteins will be released, sir. Actually, మర్చిపోయిన గ్లైకోపెప్టైడ్స్ వచ్చి ఇన్సులిన్ రిసెప్టర్స్ బైండ్ అవడం వల్ల ఇన్సులిన్ అనేది యాక్షన్ తగ్గుతుంది సార్. ఫ్యాటీ టిష్యూ నుంచి రిలీజ్ అవుతాయి. యాక్చువల్లీ అది ఎగ్జాక్ట్ గా గుర్తులేదు.
When do you say that there is insulin resistance? When the requirement crosses over?
Don't know. ఎంత సార్? ఎంత సార్ తెలియదు.
100 units.
100 units.
24
per day, sir.
Per day.
Per day 100 units. Okay.
Then you have to switch over purified insulin, like human insulin.
Okay, sir. Okay, sir. ఇంకేమన్నా ఉన్నాయి సార్ యాడ్ చేసేది?
నాకు ఆన్సర్ తెలియదు కానీ వాట్ ఈస్ డాన్ ఫినామినా?
డాన్ ఫినామినా చైతన్యకి తెలుసు, రీసెంట్ గా తను డయాబెటాలజీలో డాన్ ఫినామినా ఐడియా లేదు సార్.
అంటే యాక్చువల్ గా ఎర్లీ మార్నింగ్ దేర్ విల్ బి హైపర్ గ్లైసీమియా అన్నమాట. దానికి ఏంటంటే నైట్ డోస్ ఇన్సులిన్ ని తగ్గించాలి.
ఓకే ఓకే.
బికాస్ ఇన్సులిన్ యాంటగోనిస్ట్ అన్ని ఎర్లీ అవర్స్ లో ఎక్కువ సెక్రీట్ అవుతాయి.
ఓకే సార్. ఓకే,
అది ఒకసారి వెరిఫై చేసుకోండి. కరెక్ట్ నేను
సార్? అవును సార్, ఎర్లీ మార్నింగ్ ఇంక్రీజ్ ఇన్ గ్లూకోజ్ లెవెల్స్. అదే సార్, అదే.
ఇంకోటి ఏదో కూడా ఉంది, సమాజ
ఫినామినన్ సార్.
ఏం ఫినామినా?
సోమైజీ ఫినామినన్.
ఏంటి
అంటే
దట్ ఈస్ ఎర్లీ మార్నింగ్ హైపోగ్లైసీమియా సార్.
ఎందుకు వస్తుంది? దానికి ట్రీట్మెంట్ ఏంటి?
రెడ్యూసింగ్ ద నైట్ డోస్ సార్.
మరి దీనికి దానికి తేడా ఏంటి? డాన్ ఫినామినాకి సోమాజీ.
దట్ ఈస్ ఎర్లీ మార్నింగ్ హైపోగ్లైసీమియా. తీసేస్తానండి.
పావు గంట వచ్చేసి.
డాన్ ఫినామినా మీరు చెప్పినట్టు ఇట్ ఈస్ డ్యూ టు the hormones that act antagonistic to insulin, and somaji is due to increased effect. I mean, this is also hyperglycemia, but this is due to the hypoglycemic effect. అంటే ఇంక్రీజ్ నైట్ డోస్ వల్ల హైపోగ్లైసీమియా వచ్చి దానికి రీబౌండ్ గా హైపర్గ్లైసీమియా వచ్చేది సోమైజీ ఎఫెక్ట్ సార్. డాన్ ఫినామినన్ లో కూడా హైపర్గ్లైసీమియా వస్తుంది, బట్ దెర్ ఇస్ నో hypoglycemic effect that causes this rebounds. That is the difference between these two, sir.
So in Dawn phenomena, you have to increase the dose of insulin.
Yes, and in Somaji, you have to decrease the dose.
Yes. You should always be careful while giving insulin because it will take potassium into intracellular and serum potassium will fall. So you should always look at the serum potassium while you are giving insulin.
Sir, good morning, sir.
Sir, good morning, sir.
Regarding this Dawn phenomena and Swamiaji phenomena, especially when we write instructions, we directly write stop oral hypoglycemics and start insulin for some patients. So when physicians are treating, what they do is they don't go for more of rising insulin dose, sir. They add one gliptins. Ideally, they add gliptin, either 10 mg, based on the readings. So whenever patient is on insulin and also on say any oral hypoglycemic during night time, so once we have to ask him about history, because why this extra tablet was added specifically in the night time. Most commonly, what they do is for early morning rise, they don't increase the dose; they keep a standard dose and add one oral hypoglycemic, sir. As of my knowledge, most commonly gliptins are added. So whenever we are coming across this situation, we have to once take a proper history about what happened initially. Is there any hypoglycemic episodes early in the morning, or else any nighttime issues regarding fall in sugars? Thank you, sir.
Okay, thank you, sir.
And also, while adjusting the dose of insulin, you should always calculate the 24 hours requirement of the insulin. And you divide into 2/3 and 1/3. 1/3 depot insulin is given in the night, and there are 2/3 is just.
Hello.
Hello.
Sir, ideally, what we do is we calculate that and put on, as you told, sir, but it also depends upon the calorie intake of patient also, sir. So what we do is we always prefer for lower side of dosage when we are prescribing it to patient. So we give some suggestions, but calorie intake is not completely in our hand. So ideally, though we suggest that 2/3 dose to be given, it only depends upon sugar readings initially, and then only we can switch on to whatever you want to do, sir.
అదే సార్ చెప్పింది యాక్చువల్లీ కరెక్టే. అంటే వి చెక్ ఫర్ అ ఫ్యూ డేస్, అంటే కొన్ని రోజులు చూస్తాం వాళ్ళకి డైలీ ఎంత ఇన్సులిన్ అవసరం పడుతున్నది అని చెప్పి, అండ్ దెన్ వి క్యాల్కులేట్ ద డైలీ రిక్వైర్మెంట్, ద యావరేజ్ డైలీ రిక్వైర్మెంట్, అండ్ దెన్ వి డివైడ్. అంటే ఆబ్వియస్లీ వాళ్ళ క్యాలరీ ఇంటేక్ అలానే ఉంటుంది కదా, సో వి అబ్జర్వ్ ఫర్ అ ఫ్యూ డేస్ అండ్ బేస్డ్ ఆన్ దట్ వి క్యాల్కులేటెడ్ 2/3, 1/3. సో ఆ క్యాలరీ ఇంటేక్ కూడా దాంట్లో కలుస్తుంది అప్పుడు, అంటే వెన్ వి అబ్జర్వ్ ఫర్ ఫ్యూ డేస్ అండ్ గివ్.
ఓంకార్ సార్, ఆఫ్టర్నూన్ కేసెస్ కి ఏం చేస్తున్నారు సార్? డయాబెటిక్ పేషెంట్స్ ఆఫ్టర్నూన్ కూడా కొన్ని కేసులు ఉంటాయి కదా సార్, ఎన్బిఎం మార్నింగ్ నుంచి ఉంటారు.
చెప్పండి ఏంటి గణపతి.
అదే ఇప్పుడు కొన్ని కేసులు డయాబెటిక్ కేసులు మార్నింగ్ నుంచి ఎన్బిఎం లో ఉండి ఈవినింగ్ అలా పెడతారు కదా సార్ కొన్ని ఒక్కొక్కసారి. వాళ్ళకి అంటే డిక్రీజ్మెంట్ ఒకటే పెడతారు, ఇంకేమన్నా other
insulin potassium solution, best maintenance solution for diabetic, 100 ml per hour.
అది ఒక్కటే సార్,
అదే
జస్ట్ అదే.
Correct me if I'm wrong, but major surgeries ki patients when they are getting admitted, I mean they'll be admitted obviously mostly 1 or 2 days prior. So after their admission, if it's a major surgery, it is always, I mean I feel it is better to stop their oral hypoglycemics by the time they get admitted. And according to sliding scale iste, I mean it is better intake than అనిపిస్తుంది సార్ for major surgeries though.
అవును.
And they should plan the surgery in the early morning. All
అదే నా దగ్గర సింహాచలం సార్ ఆఫ్టర్నూన్ చేస్తారు కదా సార్.
కాదు, a patient if he is having a 500 blood glucose and they are planning to do surgery in the afternoon, how rapidly we can decrease the blood glucose levels?
Actually,
Really, we should not even pose that case. Sir. If it's
more than
an
300 are ketoacidosis, sir. Postponed for elective cases, these two.
Emergency అయితే
ఎమర్జెన్సీ అయితే patient might have ketoacidosis or hyperosmolar.
యూరిన్ ketones నెగటివ్ అనుకోండి,
ఇన్ఫ్యూషన్ స్టార్ట్ చేస్తాం సార్. IV ఇన్సులిన్ ఇన్ఫ్యూషన్
ఎన్ని పర్ అవర్ ఎంత డిక్రీజ్ చేయొచ్చు ఇన్సులిన్ గ్లూకోజ్
పర్ అవర్ 20.
Can I take this question?
yes
Sir.
sir.
Yes.
Yeah, normally for any hyperglycemic emergency management, we target not more than decrement of 50 to 100 per hour.
Okay, sir.
There is no urgency to decrease the blood sugars, just looking at the blood sugar only. So we can, because now if it is surgery, we need not require it is 100 only blood sugar. We can take up the surgery if it is an emergency, even if it is 900 also. But keep it in mind that there is a possibility of decay can also happen in this patient. Hydrate the patient. Slowly decrement expected around 100 milligrams per deciliter per hour, and we can target it over few hours.
Okay, sir. Thank you, sir.
Thank you sir.
And I don't think that there is a specifically before taking up the patient, his sugar should be around 100. Whatever may be the sugar, if it is an emergency, we'll take up and we'll maintain it as insulin infusion, hydration, taking care of acidosis if it is there.
What is the rate of secretion of insulin per hour in humans?
Maximum, sir.
Per hour ఇంత మనం
0.1
మెటబాలిజం కి
and 0.1 unit per kg per hour usually పెడతాం సార్.
yes, 0.1 unit per kg per hour. కాదు, కొత్త క్లాసిఫికేషన్ ఆఫ్ ఓరల్ హైపోగ్లైసిమిక్ చాలా 5 or 6 వచ్చినాయి. మనం చదువుకునేప్పుడు 2 or 3 ఉండేది.
ఓకే.
These new drugs, they cause hypoglycemia, metazones.
Yeah.
Okay.
Actually, mostly now they are looking into the disease specific management of hyperglycemia. Maybe
Okay.
cardiac patient with hyperglycemia, renal patient with hyperglycemia. So we have to tailor the medication. We choose the medicine depending upon the background disease. We are not only dealing with diabetes, we are also dealing with maybe diabetes with acute coronary syndrome, or patient is having a heart disease, or a diabetes with patient having a renal disease. Depending upon that, the choosing of anti-diabetic medication is preferred.
Okay.
Because there is recently one medicine came, which is, even though patient is not diabetic, though they classified under diabetic medication, it is a drug of choice for heart failure management. The patient is having heart failure, we use this medicine even though his sugars are normal, but it is actually classified as a diabetic medication.
It's a parent, sir.
I'm not able to recollect. I'll just tell you once this discussion is going on. Recently it is in the heart failure management also, some publications were there. They started giving this medicine, though it is classified as anti-diabetic, but it is good for heart failure management. I'll let you know, or I'll put it in the group.
Okay, sir. Renal failure with diabetes, the best drug, sir?
So that is one thing. So certain drugs, I'm not sure which medicine it is, but I'm just throwing light on certain situations. Like,
Okay.
see, basically when my patient is having diabetes, I'm choosing a medicine which increases the what is that called as excretion of the insulin sugar from the renal tract. So if that's the one medicine is directed to decrease the sugar by increasing its excretion through the kidney. If the patient is having a renal failure, that medicine won't work there. Understand my point?
Yes, sir.
So, sir, see, sugar management it can be different varieties. Depending upon that, we have a classification of medicines. But one class of medicine just manage the sugar by increasing its excretion through the kidney. If the renal failure is there, that medicine won't work. If the patient is having a recurrent urinary tract infection and fungal infection, better to avoid that medicine, because that patient urinary concentration of sugar is more, and that urine is logged into the bladder, and that is a very good culture medium for a fungal infection.
Yes.
So those are the things we cannot use that medicine either in the renal failure or recurrent UTI due to fungal infections. So this is how the actual medications to be chosen in between. So depending upon the background situation of the patient.
Okay, sir. Thank you, sir.
And one thing is, like, from the critical care point of view, I'm not just worried about this. GA regimen is still they're using, because the caveat for that is, one is fluid overload, second is like lots. Normally we give 100 ml every hour.
Yes,
In that,
sir.
some 2 milliequivalents or 1 milliequivalent of potassium or 2 or 1 unit of insulin, something is that I followed in way back in 1990s. So still we are using the GIK regimen, but some people say that it is lots of fluid overload. No, 100 ml per hour into 24 hours is only for the sake of insulin management. We are giving 2,400 ml.
You are using insulin infusion, sir.
Sliding scale we use.
Sliding.
Yeah, that is also. So even now that American Diabetic Association or Indian sliding scale is also not advisable. I heard that. I read through some articles.
Okay.
Previously, we used to put, like, if the sugar is less than 100, no insulin, 100 to 152 units, 150 to 200, 3
Yes,
units.
sir.
Some scale was there.
Yes, sir.
That was, and after that, in 19s, it was very, very passionate to go with GI regimen for particularly pre-op and intra-op, immediate pre-op and intra-op. But that is also because we used to take like separate Biret meter in that 100 ml refill, and then put 2 units of insulin or 2 milliequivalents of potassium, run through 1 hour. But that is also mounting to the volume overload to the patient. So then they came up like insulin infusion directly, just to make 40 units and 40 ml of normal saline or anything. Start with 0.5 ml per hour or 1 ml per hour, and try to titrate the sugar levels as if
Yes.
it is managing of a DKA.
Yes, sir. Thank you, Satish, sir. And thank you all.
Thank you, sir. Thank you very much. Bye-bye.
Thank you, sir. Thank you.